lives are in your hands, and she wants you to be good at what you do. Now we got to focus on anesthesia pre-op. Sometimes patients come in to the hospital a week ahead of time, the day before. They get their EKGs, their labs drawn, they get all their pre-op stuff, that their education. They may stop at an anesthesia office and get all that stuff, the anesthesia portion of the care taken care of ahead of time. Where I work, the first time I see a patient or know anything about that patient is when I see him. So I just came out of a case. Drop my patient off at PACU, get report, go to the next. Well, hopefully there's a bathroom break in there, but not always. Go see my patient. I have like 3 to 5 minutes to take care of them. I've never seen them before, based on what's in the computer, based on what's on. We still have paper and computer charting where I work. What they tell me, what their family tells me, and I have 3 to 5 minutes to get that done, and we're rolling back. What? It's true. So if I work at a place where they see them way ahead of time, I'm like, some other anesthesia provider has seen them, given them education. You know, you just kind of feel your few minutes with them is like, I already got this because somebody else has already seen it. In my case, I'm like, this is it. I'm it. Now, if I'm lucky, my anesthesiologist that I'm working with had a chance to say hi and kind of do an assessment. Maybe, just maybe, we've had a chance to talk about this patient beforehand. Maybe not. You're going to have to learn to find out what's important. Well, everything's important, but you're going to have to be able to focus in what's going to make a difference to you being able to take care of that patient safely when they're under your anesthesia care. So that's what today's about. We start out kind of gentle with it. I've included my PowerPoint. This has been done and redone by several people throughout the years. And then there's also the big one, Dr. McDonough one. It's like 192 slides, and then there's one that Allison Goldfarb kind of redid, and there's like 101 slides in there. We're going to talk about, our focus will be this one, and the study guide, the reading, but we'll talk about what's most important in the cardiac one, because I think it's Principles 3 is where you do your big cardiovascular stuff. But I want to get you enough basics so that as you start these assessments, when you go to your clinical sites, you'll have some basic knowledge. Now, some of you may be experts in cardiac. Help your buddies that are not. All right, so that's what we're going to talk about today, pre-op assessment. I'll also try to, clear up any questions that you might have related to the 2 exams or exam and quiz. No, I can't do that. I won't do that. All right, so the objectives of today really are just to get you familiar with this anesthesia pre-op assessment, to get you comfortable with the steps, the routines, what we're looking for. It's really not much different than when you were an ICU nurse, except now you're the one that's going to be doing anesthesia, which means taking the person deep sleep so that they're not going to respond when the surgeon does that incision. Wow. And you've got to watch the hemodynamics the whole time to keep them safe, because the things we do make blood pressure drop, make heart rate lower, make them stop breathing. So you've got a lot of responsibility. And it all starts with coming up with a plan. The way you come up with a plan is pre-op. So as you think about doing your care plans, when in real life you look at that patient, you assess that patient, you consider what kind of surgery are they having? What do they come to me with? What kind of comorbidities do they have? Is their physical classification status, that's the ASA, is it 1, 2, 3, 4, 5, 6? Well, 6, they're not going to be talking to you too much. And what do we do if it's an emergent or emergency case when we get that classification number? We add an E to it. Does that make sense? So if I have someone that doesn't take any medicines for anything, they're very healthy, they have no previous medical history, they come in level 1 trauma because they were in a motor vehicle accident, what would we make their ASA status? 1E. Don't forget the E part, if that's in your scenario when you're looking at an exam, for example. We might say emergency, we might say emergent. And based on what it is, multiple gunshot wound, could be a lot of different things, motor vehicle crash, emergency trauma kinds of things. You should be able to determine their ASA classification. But when we talk about pre-op assessment, you have to think about how all this happens. What's the patient flow? The patient comes into the hospital and says, where they do that initial intake, they'll say, hey, my name's Davron Harmon O'Connor. I'm here to have a lap chole today by Dr. Chapano. They go, oh, okay, sit down. Show me your insurance card and ID. Just saying. So they kind of admit me to the day for the hospital to have that surgery. So patient flow, I come in, I get admitted, then they're going to send me to the surgery center where they're going to get me ready for surgery. Take all your clothes off, all undergarments. What? I think I'm just getting my big toe. Yes, all undergarments. Put you in one of those gowns so you can flap in the wind. That makes people comfortable. They put the cap on, protect hair, kind of tuck it all in there. They start an IV, and that's always a pleasant experience. Different places do that differently. Some places, the anesthesia providers start that IV. Some places you're going to go to, it's already done in a pre-op center, unless they can't get one. After they get checked in there, then they send them to the OR pre-op holding. We're talking about patient flow. They get up to the OR pre-op holding, and then they're going through the nurses there that check them in are going to go through that checklist. Are they in PO? Do they have an IV? What are the antibiotics that are ordered? They're going through their little thing. The patient's like, I've already answered these questions. Like, this is now the third time. Okay, we want to make sure it's you. We want to make sure it's safe. We want to take really good care of you. That's why each person has their own focus. That's why we're asking these questions over. Can't you just look in the chart? Yes. But I care about you and want to take good care of you. So that's why I'm asking, because I'm looking at the anesthesia part of this. Okay, so they come in to the hospital. They get checked in. They get sent to the surgery center to get prepped for surgery. Then they go to the pre-op holding area. They get in the pre-op holding area. Everything should be ready. The pre-op nurse gets them ready. Then the OR nurse comes in and does their part. Again, now here's like the fourth time they're asking some of the same questions. All those questions are important. And then guess who they meet? Question. Anesthesia provider comes along, or the surgeon comes along. Usually the surgeon says, anything changed since the last time I saw you? Yes, no, okay, you're done. Anesthesia comes in my place again. We haven't seen them before. So we don't know them from anybody. We don't know anything about them. So again, we have just 3 to 5 minutes to figure out what we need to do to take good, safe care of this patient. So I'm going to do an assessment. There are different ways to approach your assessment. You can do it. Let's look at the chart first. I don't like that approach. If someone's up at the bedside talking to a patient, I'll do that. I'll look in the chart. Why waste time? I'm here, only got 30 seconds anyway. I'm looking at the chart. Well, and then as soon as I have a moment, I go, hey, my name's Davron. I'm nurse anesthetist. I'm going to take care of you. I was just looking in the chart. I didn't want to interrupt. A lot of times I can learn things from whoever else is talking to that patient is going to help me out, so I don't have to ask those questions again. But when I get there, I'm the 5th or 6th person asking these same questions. What are you allergic to? Any metal in your body? When's the last time you had anything to eat or drink? After I do my assessment, then they're going to go to the OR. After they're done in the OR with their procedure, surgery, then they're going to go to PACU. They're going to be recovered there. After PACU, they're going to go basically 1 of 2 places usually. Could be 3 or 4 depending on your religious beliefs, and if they survive the surgery or not. When they get to PACU, they're going to be admitted as an inpatient, and then go to the floor, surgical floor, medical floor, CVICU, heart floor, where they're going to go to the floor, or they're going to go back down to where they came in initially to the pre-op center, the surgery center there, to then be discharged home. So that's the patient flow. And it may be a little different in different places. Sometimes these get combined. You might have two stations at one. It just depends on where you are and how big the hospital is. For us, we have all these little stations. There's a ton of places they go. They meet 1 million people. So it's always important for you to introduce yourself, what your role is, what you're going to do for them, how you're going to help them. Because again, they see 1 million people. And I might be exaggerating a little bit, but they're going to see, anywhere from 6 to 10 people as they get ready to have this surgery. And they're like, they see somebody in scrubs with their head covered. They're like, okay, is that a doctor? Is that a nurse? Is that a tech? Who is that? So always say who you are, make sure you say what your role is. So that's basically patient flow. So when we look at different procedures they're going to have done, are they having surgery done or are they having a procedure done? So let's see, what would be the difference between surgery and procedure? Any examples? Colonoscopy would be what? Okay, that's a good example. Anytime you have a scalpel involved in an incision, that's going to be what? All right. If they come in to have an MRI done, what would that be? Sometimes they cross the line. So sometimes we combine procedures with surgery and anesthesia. It just depends. But you should be able to have or recognize some differences between what's something that's strictly surgery and something that's strictly procedural. Okay, kind of have in your mind, run through some different scenarios, talk to your buddies when you're studying, figure out some of those. Now, when I figure out what I'm going to do, part of it depends on how well I assess this patient, and then what are my anesthesia considerations. So, wow, I have to think about everything. How good am I? Oh man, I'm so good. When's the last time I did a central line by myself? When's the last time I've done a central line? It's probably been 8 years. What? Now, in that time, I've been away in the Army 5 times, haven't done a central line. In that time, I've probably done, I don't know, 9,000, 10,000 cases. So if I know that about my skill set. Now, I used to be able to do them, but I'm not good at it. So if I need to do one, I'm going to work with the people I'm working with, whether it's an all-CRNA group or I'm being supervised by a physician. I'm going to say, listen, I haven't done a central line in 8 years. I need some guidance. I'd like to do it. I'm always like, I want to do it. Here's my chance. So then I can say, oh yeah, I did one last week. But I need some help. I'm rusty because I haven't done it. Now, what am I going to do the day before when I think I'm going to have to do one, man? I'm going to go to YouTube. I'm going to look at my references, resources. I'm going to walk through the steps in my head. I might even practice at home. Poor Dawn. It won't hurt. So I'm going to do that. So I've been doing the anesthesia for a while now. But I would be in the same place that you are, in terms of you probably don't have a lot of experience doing central lines unless you were a nurse practitioner on a, in ICU, like an acute care nurse practitioner in your past, or CVICU practitioner or something like that, and you would have way more experience than me. Now, does that mean I'm not a good CRNA in my mind? No. It just means I'm going to be honest about my skill set, so that when I'm taking care of this patient, I'm not putting them at risk. That being said, the Army sends me away, and I have these skill sets that I'm weak in. I'm going to do everything I can to beef those skills up before I go away. But I have found that when I go places and say, okay, here's what I do, here's what I'm really comfortable and confident with, and here are some things I need practice with because I haven't done it, they respect that. And I'm not putting my patient's safety at risk. However, if I act like I did that in school 12 years ago, not a problem. I can do it. I've done it before, right? And you just go in, no prep, no review, and you know you haven't done one in 8 years. Would you want that to be the person you love that you're taking care of? The answer is no. So be honest with your skill set that you have so that you can take good care of your patients. That's what that preaching was about. Once we've assessed this patient, we come up with a plan. We always have an anesthesia plan, and usually you have plan A and then plan B. A lot of times I have C and D in the back of my head too, just in case. Sometimes you make your plan, I'm ready, and then you finally connect with the anesthesiologist you're working with, and they say, oh, no. And you're like, plan B. What do you suggest that we do? Then you're like, you already set the room up for something else. And then they're like, I don't have a propofol pump in there. And then you run around trying to get everything ready. It still usually works out pretty well. Okay, then you get in there, and you talk to the surgeon, and they go, we don't need that. All we need is a little sedation. We'll put some local in there. No problem. Then you're like, oh, plan C. Yeah, so you kind of have to be ready for everything, right? And you have to have plan A and plan B. When I'm thinking about this patient, what they're having done, who I'm working with, my skill set, comorbidities of the patient, I'm thinking, here's my plan. I coordinate usually as quickly as I can with the supervisor I'm working with. Is this what you're thinking? Here's what I already tell them. Here's my plan, anything you want me to do different. I don't usually say, what do you want me to do? I usually say, here's my plan, anything you'd like me to change or do different. They'll say, oh, no, that's fine, perfect. I'm happy, you're happy, let's go back. And then, sometimes again, the surgeon, they'll throw you a little loop. It's okay. Then if there's differences between what the anesthesia team wants to do and what the surgeon thinks should be done, I let that, where I work, I let that be a physician-to-physician conversation. So I don't get in the rip where she's going, yeah, I did that. I don't want to be the one in the middle of that. Now, if I'm in a CRNA only practice, I have no problem talking to that surgeon and go, this is, I believe, the safest thing for us to do, and here's why, X, Y, and Z. Here's what I'm concerned about. And they're like, when you talk about the safety issue, they're like, okay. But it's only going to take me 5 minutes. Okay. It only, and I'm like thinking, yeah, the last time you said that, it took like an hour and a half. I'm not going to say that. I'm going to think that. I'm going to go, well, let's err on the side of safety. It will take a little longer to go to sleep and to wake up and to have them to recover. They won't be walking out of PACU, going home, but I want to make sure they go home. They're like, done. Perfect. Plan A, plan B, plan C, plan D. When we assess our patients, I'm already thinking about what do I want to do for them in PACU? Because I have to do pre-op orders for anesthesia. I have to do my intra-op anesthesia record. Along with that, at the beginning, I have to get a consent from them. I have to tell them about the anesthesia plan, the different options. I don't usually tell them every single option. I usually give them, yes, these are the ways we can do it, but we feel like based on all the things, based on this assessment, we feel like the best thing for you and what the surgeon requires for this, that we're going to offer this. We always have a backup plan for you, but this is the one we really feel like we would be the best and safest thing for you to do. Okay, that's good. So I'm doing pre-op orders, I'm doing my intra-op record, then I'm going to do PACU orders. If they're allergic to Dilaudid, and I say, well, what is the allergy? How does it affect you? And they say rash, I'm not going to order Dilaudid. If they say, well, it makes me sleepy. Okay. People will list allergies that are not true allergies. I don't contradict them at all. I'll just say, well, all drugs have a main effect and side effects, and that's really a side effect of the drug, but because you have that reaction to it, we're not going to get it. Sometimes I do even a little more education. An allergy would be if you have a rash, if you have swelling around your face and your airway, you have trouble breathing, your heart, blood pressure kind of are affected. Oh, well, that's not what happens. All right. Oh, if it's a scheduled procedure, you are in luck. And where I work, almost all cases are elective. Almost. We get people from the floor that had surgery that are bleeding out that come back. We get some emergencies in the night. Lap appies come to mind, get a lot of those. But we're not a level 1 trauma center, so we're not getting the motor vehicle crashes and the local gunshot wounds like you'll get at Tampa General, you'll get at UF Health. Most of the people I take care of are there for elective surgery. Now, it needs to be done. It might be urgent, but I don't take care of emergency cases that often. Occasionally, maybe a couple times a week, not much. At UF Health, you'll probably see daily, and maybe more than one a day, depending on where you are. If you're up, on a trauma rotation or what. All right. So if it's a scheduled procedure, we already talked. They go to the doctor and the doctor says, "Hey, you've got problems with gallstones." And they go, "Yeah, that's why I've been having all this problem." And then so the doctor says, "I'm going to refer you to Dr. So-and-so, this is general surgeon, to get that taken care of." And they go, "Okay." So then they call the office, they make an appointment, they schedule it. Always try to be the first case. And I tell that to my family and friends. But not everyone can be the first case of the day. But if it's you or your family member, try to be the first case of the day if you can. Because sometimes when cases go on, sometimes it's quick and easy and it goes that hour that it's scheduled to go. But sometimes it goes 2 hours. Well, then if that's the case, and you're the second case, then you're an hour behind. And let's say that one takes 30 minutes longer than they thought. Now we're an hour and a half behind. By the time you get to the third, fourth, fifth case of the day, you've been there like half the day, 4, 5, 6 hours, and you're like, so I always like to recommend people try to go earlier in the day if possible. It's a good thing. When they come in, they're going to get admission orders. The surgeon's going to have these admit orders and tell what you need to do for that patient. So the pre-op, the surgery center is going to do that. The pre-op nurses are going to do that. They get put on a schedule. They do a pre-op evaluation with the surgeon. So they do their H&P. And then they're also going to do it with anesthesia. A lot of places, that's the pre-anesthesia testing area. UF Health has one. A lot of places have their own office. They come in again the day before, the week before to get that done. In our place, that happens like 2 minutes before we go back. We're going to talk about the surgery. They're going to give them some education. Then they're going to also talk about what to expect afterwards and when to follow up. Are they going to come back a week from now, 2 weeks? We're going to take the stitches out in 3 days, whatever it is, they'll tell them. All right. The first part of our assessment is this, point of encounter. Hi, my name is Dave Brown O'Connor. I'm a nurse anesthetist. I'm going to take great care of you today. I'm doing the anesthesia part of your care. I'm also working today with Dr. So-and-so, the anesthesiologist. We're working as a team to take good care of you. Or many times I'm saying I'm also working with student so-and-so. They're going to be here working with you too. So you've got 3 of us to watch over you, take great care of you, to watch every breath, every heartbeat, to help you get through this safely. That's kind of my spiel. But what I'm doing here, I'm reducing the amount of Versed that I'm going to need to give. That's not really what I'm doing. I'm building trust and rapport. And if they feel trusted, that they can trust me, they feel safe, they feel more secure, and they may still want Versed, and I'm glad to give it to them. But that's the first part of my assessment is building that trust and rapport with that patient. Again, if you have a chance to do the clinic, it's great. And you will get plenty of opportunities probably in your career to go to those clinics. And usually that encounter probably wouldn't take more than 5 at the max 10 minutes. But just like the bed bath when you were first a nurse, it took like half a day. It took like an hour to do a bed bath, right? I mean, really. Didn't it? It took an hour to do those bed baths. And then afterwards, you're in ICU, you've been doing this for a year or 2, and also, 5 minutes or less. I know you're laughing, but you know what I mean. This will be the same way for you. Doing your assessment, it'll be kind of slow at first, but you've got to learn to be able to be more efficient with it, and that will come in time. That will come in time. Some places actually do a phone interview instead of coming to a clinic. I haven't worked at a place like that, but a lot of surgery centers will do that. Okay. Interview goal. We want to know about their procedure, their medical history. We want to do that point of encounter, establish a relationship with the patient and any family that they have there too. So you make sure the patient is comfortable with what you're up to, and make sure you always ask the patient, first of all, I always say to the patient, and who did you bring with you? I stop saying, is this your husband? Is this your wife? Is this your daughter? Like, it only takes one of those traumatic experiences on your part before you change how you say things. Oh, it's so embarrassing. Then you just want to crawl in a hole, and then you're thinking, oh, I'm building trust and rapport here. Usually I would just say, I am so sorry. And hopefully you did it in a way that was complimentary as opposed to not. So I'm warning you ahead of time. Be careful of how you say it. And because you're nervous maybe at first and you don't have your routine down in your head about how you're going to do it, some of those slips happen. Just apologize, mortify on the inside, and just be confident on the outside. Just go past it. You're going to be red probably. It's okay. Once we've seen them, we develop a plan, and we're going to have how many plans? At least 2, A and B, right? And maybe you're in your head going, well, I could do it this way, I could do it that way if we need to do something different. We're going to talk about patient education and the plan and the flow if they don't know. And we're going to get informed consent. Now, as students, you probably won't be giving informed consent. Some places you will, depending on your clinical sites. You have to find out what the protocol is at that place. Where I work, when I'm working with a student, either the anesthesiologist must see that patient first or the CRNA must see that patient first before we can get consent. Now, you could tell the patient, the plan is general anesthesia today. You could go through the informed consent with them, but don't get them to sign in my place until they've been seen by an anesthesiologist or CRNA. That's a liability thing in our place, and that's where we have to do it. Now, some places you'll go and they say, get the consent. You're like, okay. All right. Lots of things included in that informed consent. You're going to tell about the options, bless you, different kinds of options related to anesthesia for this procedure. You're going to talk about possible risks. Now, some people go through every single detail. You can die from this. That's not how I start. You could start that way, but I don't recommend it. So I usually say something like this. Anesthesia is very safe today. There's always a risk with any surgery or anesthesia. Every single time you have it. You've had surgery before with success. I expect you to be successful today. But it's important to know there's always risk. Anything between breathing problems, heart problems, and everything in between can happen. Any questions about that? They go, we know the risk. And some people say, listen, I don't want to know anything. And I'll say, well, that's fine. But are you willing to sign a consent that you realize there's risk? And they say yes. I don't say anything else. Now, some people, I hear my colleagues sometimes go, well, this could be including death. And they're like all the stuff. And I'm like, okay, good for you. Now, again, most of my surgeries are elective. So I'm usually not thinking that death is a real option here. That being said, when I'm taking care of an ASA 4 patient and they're having a AAA, or someone that has really bad lungs, and I'm thinking we might have to keep them on the breathing tube, do I include that in my consent? You better betcha. Yes, I do. That sounded pretty like Minnesota, didn't it? Oh, it was cool. Yes, or in South Dakota, maybe. I tell them that. I say, because of the heart problems that you have, or because of the breathing problems you have, it's very possible we're going to have to keep this breathing tube in overnight or until it's safe to take out. And I tell them with the family, everybody, I don't expect to do that usually, but just so you know, because of the conditions you're coming to us with, you're at higher risk for having to do that compared to someone that doesn't have that lung problem or heart problem. So I make sure I tell them. If I'm going to start a second IV or they're going to have an art line or we're going to put a central line in, I tell them ahead of time so they and the family kind of know what to expect. Doesn't mean anything went wrong. It just means we want to take good, safe care of you. So we're going to start with a second IV. So you'll see another one probably on the other arm. We might start an art line. So I just tell them. Usually they just say, I trust you. You're a professional. Okay. Why do they trust me? Because I already developed a relationship with them. Hopefully. You will get there too. All right, one of the things you need to do is to look at the chart. Now, most places are, I would say a lot of the places you're going to go to are electronic EMR, some are paper, and some are in between, or like us, we have a hybrid. So we have to do both. It's really making things much faster and more efficient. They have to do both, just for the record, yeah, it's awesome. So one of the things about getting oriented to the clinical site you're going to go to will be having computer access. For your observation days this semester, you will not be having computer access. Now, I say that's the plan. Sometimes you may go somewhere and they say, hey, while you're here, let's go ahead and have you go through the orientation class, or let's have you do some prep. That's fine. You just go with flow. Sure, I'll be glad to do that. Where I work, we don't give students access to the computer at all. So I get to be the computer lady. Well, you guys get to do the actual patient care. This is awesome. Usually I can keep up with that, watching you guys do your thing. But you must look in the chart, and then there's a question. The Dr. McDonough method or the, I'll just say, other method. This is my boss. So I like his technique. He says, I don't even look at the chart till later. Now, that means later means after you've already built trust and rapport with the patient. So I like the idea of hearing the story from the patient and family first, and then going to the chart and going, oh, what about the potassium level? What about their H&H? What about this? What about that? What about the chest x-ray? What did it say? What about the EKG? What does it show? But I like to get everything from the patient or the family first, and then go to the chart. But like I said, if someone's already doing their part with the patient, when I walk up, I just start looking through the chart first. So my normal thing is talk to the patient first, then go to the chart. And that would be I learned from my great leader, Dr. McDonough. That's his technique. Talk to the patient. That's where you're going to find out what you need to know. Now, you need the chart too, and you have to do a chart review, whether it's a paper one, you're flipping through the section that says testing or anesthesia. You need both, but your technique may change depending on where you're doing your clinicals. So you may have one provider, CRNA or anesthesiologist, that says, always go to the chart first. And you say, yes, sir, yes, ma'am, I will do that today or any time I work with you in the future. Then you work with somebody else like me, and I say, or Dr. McDonough, and you say, always go to the patient first. Always, always, always go to the patient first, then go to the chart. And you'll say, yes, sir, yes, ma'am, that's what I'll do today. That's what I'll do every time I work with you. Yes.
So I just have a question about that method. It's like how many times do you find that you find something in the chart and then you're like, oh, I didn't know this. I need to go back and ask the patient about this, or is that?
Usually that doesn't happen. It does occasionally. But again, that's still part of my 3 to 5 minutes. And I've already, in the morning when I get there, I always go early, and I've looked at all of my patients usually before my first case is started. So I've already looked at the electronic stuff.
Okay.
And usually when I start their pre-assessment computer note, it's based on what drugs they take. Because sometimes there's an H&P from the surgeon, and sometimes there isn't. And I'm like, oh, well, it looks like they have hyperlipidemia, hypertension, or it looks like they're on metformin, so they probably have diabetes, and, you know. So I literally have looked at the chart already, because in the morning I get ready for all my patients. Because in my morning, when I get there, I do all the pre-op, what is it called? Pre-op orders, anesthesia orders. I do all those. And then I look at the H&Ps. Sometimes I don't have time to do them all, so I do it when I'm in a case for the next one. So sometimes I have to do it that way. So typically, I think I just lied to you, but I didn't mean to. Typically, I look at the chart before I see the patient, because that's the routine I have, and I have to do pre-op and post-op orders for those patients. Right. So I usually get to do that.
So you have some background.
Usually I do. Usually I do. But if I don't have that option, like when I go to a surgery center, a lot of them don't have computers. It's expensive, so it's all paper chart. Like, all I know is when I first come up and go, hi, I'm Dave Brown, and I have to look at the paper chart. I always start with the patient first, and then I go to the chart. Now, I have to see both before I go back, but you learn to get really good, really quick about what's important. And a lot of the outpatient surgery, ambulatory surgery centers, you don't have labs. You don't have EKGs. You don't have chest x-rays. Those are the people that they're sent into the hospital because they're higher risk. So their chart's pretty easy because they've already done either online sometimes, a history and an H&P kind of thing, or they've done it on paper. You can go, it's a one-page thing, you just go, and then you ask questions. And then you'll learn to say, like they'll have nothing on there, and then you'll say, well, does your spouse say if you snore? Mm-hmm. So then you'd be presumptive, what? Okay, yeah. So if someone just looks super pale and kind of frail, may just be a function of melatonin in the skin or age, or it could be that they're anemic. So ask them kinds of questions related to that. So you'll get good at it eventually. But I didn't mean to lie to you, because really I do usually look at the H&P before I go in. And again, sometimes that in the chart is, in my electronic record, it might just be their allergies, their BMI, and what meds they're on. I go, oh, well, I'm going to look for these things. And then when I get there, sometimes the story is very different. Sometimes it's a much prettier picture than I thought, and sometimes it's not. Sometimes it's worse than I thought. So if I have access to a chart ahead of time, I go in early and do that. If I don't have access to a chart ahead of time, you got to do it on the fly. I always introduce to them, get that build that rapport and trust with the patient first, then go to the chart.
I think the point is, you don't walk into a room and open up their chart and
Yeah.
read it in front of the
That
patient.
sounds more like a, forgive me, a physician thing. They're in the chart 5 minutes later. You know, we're nurses. We're connecting with our patients in a different way. Being really good. And so, patient contact, building that relationship, super important. Now again, somebody else is talking to a man, I go to the chart first, and then as soon as I get a second, I introduce myself. Hey, put the chart behind, do my thing, and then go back to the chart to make sure I haven't missed anything. All right, you want to know why are they here? Okay, what's going on? What meds do they take? Allergies, reactions, and again, reactions. It could be a true allergy or not. You don't have to have that debate with them. Just what are your reactions? Whether it's a side effect or a true allergic reaction. You don't have to go into that whole thing. Just know so that you can decide if you're going to give a medicine or not give a medicine. I don't usually get into a big family history with them. It usually will be there on the H&P from the surgeon. I look at it, unless it's MH. I don't, honestly, maybe I should spend more time with this, but I don't really worry too much about what's in their family history, because I'm interested in what they're here today, what's going on in their world, their past medical history now. Now, family history really matters. Maybe there's some kind of deficiency that would matter with anesthesia. Do you know what it is? Thank you. So that would matter to me, right? So that's a family history thing that would matter. MH kind of history would matter. Anything else you can think of off the top of your head? Right now I'm blank.
It's my they would have myasthenia gravis. Like that.
Yeah, they would probably already know. They would have symptoms and something. They might even be treated for it and all that kind of stuff. But so there's a few things here that would relate to anesthesia that I really care about, and a lot of the other things, you know, whether your great grandma died of a heart attack, God rest your soul. You know, that's not going to matter too much to my anesthesia plan today. You're going to do your ROS. You'll see it that way. What does that stand for? Review of systems. You're going to do your physical exam. You're going to look at in the chart the labs. When I say lab data, that would also include EKGs, chest X-rays, echoes, stress tests, anything like that. It's going to give you the information you need to take good care of that patient. Okay, so these are the systems we're going to look at in 3 to 5 minutes before you take that patient back for the first time you just around. What? Yes. Yes, we are. Now, if it's a level 1 trauma coming in, the patient's out, unconscious, there's no family there, you gotta go. You gotta save this person's life. So you don't know their MPO status, you don't know their comorbidities. You can probably tell visually if their BMI is up or not. You're gonna always assume someone that comes in a level 1 trauma that they're at risk for aspiration. So you're gonna do a RSI intubation, cricoid pressure. But this is the ideal. We want to be able to go through these systems pretty quickly. I don't think that infectious disease and MPO status are a review of systems, but they're very important things for you to know. Especially I found infectious diseases because you have to wear more personal protective equipment, PPE, if they're contagious. And then you also want to make sure you report that to everyone in the OR so they can protect themselves, and everyone in PACU so they can protect themselves. A lot of times they'll put them in a special isolation room in the pre-op area and in the PACU area so they don't contaminate anybody else. So for cardiac, the most important thing, exercise tolerance. I'm telling you, there's a reason I'm telling you this. The most important thing is what? Are these other things important? Absolutely. You don't want to blow those off or forget those. Do they have hypertension? Do they have coronary artery disease? Have they had stents? Have they had a CABG in the past? Have they had a recent MI? Whew. That's important. If they had a recent MI, we might, and this is an elective surgery, we may have to postpone until it's been 6 months, where we feel like it's safe to do it again, to do surgery again. Do they have dysrhythmias? Is it controlled? Like if they have AFib, is it controlled? Do they have PVCs? Are they coming into us, we put them on the monitor and they're in a junctional rhythm? Remember that one from that test? Oh yeah, okay. So, they are all important. The most important is figuring out exercise tolerance. So, one of the ways we ask that, are you able to do your normal activities without getting short of breath or having chest pain in your daily life? That would include going up a flight of stairs without getting short of breath or having chest pain. Now they'll say, well, I get short of breath, and I go, well, I do too. I mean, you know, you go up, because I usually go charging up the stairs, or down the stairs because I'm going to lunch. That's usually what stairs represent for me. Some kind of meal is involved here. So I am usually enthusiastic about that, and I'm probably like, after I've gone up the stairs, for about a minute, and then I'm like, normal again. And that's really what exercise tolerance is about, right? How quickly you recover after it, or when you're doing it, do you become so short of breath that it lasts 5, 10 minutes, you start getting chest pain, that kind of thing. Now there is that whole other set of slides. It's okay that you don't have those memorized. And I'll make a little things to focus on for those slides just so you can review, because those slides really are intended for more intensive principles of anesthesiology, 3 class, but you need to know some of it so you can do your assessment appropriately. So I will give you a little focus thing. I'll do that today before I leave. Of things to focus on those. One would be the Goldman criteria to determine somebody's cardiac risk for a non-cardiac surgery. So we'll talk about that. I would know predictors of things like parameters of myocardial, oxygen supply and demand, kinds of things. And again, I'll look over the exam and I'll look at the slides and give you a focus thing for that portion. So I know there's a lot of information in there, but I'll try to narrow it down for you. Okay?
Thank you.
So don't stress too much on that. You need it, and you will need it all. But we'll just focus on our immediate. All right, respiratory. Okay, so what's this? Yeah, and then there's like a BiPAP too, just on the nose. And then they have all these ones I hear on the radio, like about a little thing, I don't know. Z-Fold! You guys heard that commercial? It's happy backwards with a Z. It's some kind of special device. They have new devices here to help with OSA, and I haven't even seen them, so I can't really talk about it, except I hear the commercials all the time on XM radio. What I want to know about breathing. Exercise tolerance comes in here again. Do they have a history of smoking? If they quit, it's one of the best things you can do for your lungs. If you're smoking now, no judgment, but it's the best thing you can do for your health that you can control is to stop smoking. And lungs actually start repairing themselves in time, even if a person's been smoking for many, many years. If the damage has been done, sometimes it's not recoverable, so they may have this emphysema, chronic bronchitis, COPD issues. But a lot of times, when people stop smoking, it really can help their health in a big way. Asthma, you have to determine how serious that is. You ask questions like, have you ever had to go in the emergency room for asthma? Have you ever had to be intubated for your asthma? Is it just seasonal allergies? Let me say just. That's pretty miserable too. Is it exercise induced? What brings on that attack? So if I'm not serving shrimp, because sometimes people have an asthmatic type reaction when they are allergic to shrimp for some reason, you know, it's that anaphylactic thing that they think is like asthma. I'm not going to serve that in the OR, so we'll be okay. OSA, if they have obstructive sleep apnea, we use that thing, and maybe the next slide, I don't remember, called stopping. What I want to know here is, if they have it, do they use CPAP or BiPAP or whatever? Did they bring it with them? Because people are usually more comfortable with their own than the ones the hospitals can provide. We always have them bring it. Rarely do we need to use it. Rarely do we need to use it. But we always have the families bring it. So that's one of those things, if you're in a pre-op testing clinic, if you have OSA and use a CPAP or BiPAP, ask them to bring it. It's like in a little suitcase. It's inconvenient for them to carry, but if they need it, they'll be glad they have their own. So stop bang, what does the S stand for? Do you or someone else confirm that you snore? Usually what happens is you stop breathing, you go, and then you wake up and you're like, what's the problem? You don't know. You don't know you had it. Or haven't. But usually, if you have a significant other that you have time where you sleep, you'll get the elbow. Or you know that one commercial with the like sleep number bed where the beds go up? You see they push the button and it goes, and the OSAs, they stop snoring. I hope I'm not hurting or offending anybody. That's your situation. That's cool. I deny snoring, and then there was once a recording. So that I would become a believer. And I said, we will never do this again, will we? No, dear. We will not. I was totally embarrassed. Because I don't do it. I could have done that too. Anyway, that's another matter. Respiratory, exercise tolerance. Do they have asthma? Do they have COPD? Do they use HOMO2? Do they use an inhaler? How often do they use it? Were they ever intubated for their breathing problems? That kind of thing. All right. There we go. Stop bang. I would be familiar with these. Here's the point. There are 8 things listed, and if they answer yes to 3 or more items, they're at high risk for OSA. If they answer less than 3 items, they're at lower risk. That's the key point, and knowing what these basically stand for. Neck circumference greater than 40 centimeters, BMI greater than 35, and the rest you can just read. Those are the numbers, though, you would need to know really to stop that. Okay, renal disease. Sometimes people have insufficiency, renal insufficiency. I want to know that. Are they end-stage renal disease? Do they do dialysis? What type? Is it peritoneal? They have all the good stuff in their arm. How do they get that done? Is it Monday, Tuesday, Wednesday, or is it Tuesday, Thursday, Saturday? Those are the options. From your point of view, when you find this out, they're going to be ASA what? End-stage renal disease 2. Please take that one off your list. If we stop the dialysis.
What dialysis? 3 without 4.
If we stop the dialysis, what are the chances of survival of this patient? It might be a few days. I mean, it could be even longer. But so I'm going to say if they have end-stage renal disease on dialysis, ASA 4. Are you going to miss that on the exam if it happens to be there? And if it wasn't, am I going to write a question about that? Maybe. Oh, which reminds me, we'll go back to if someone has COPD, what ASA shall we make them? I'm going to say 3. Now, know these things about ASA physical classifications. You and the person you're working with may have different opinions. Even today, CRNA, anesthesiologists, we see the same patient. They make them a 2. I go, they're a 3. They make them a 3. I say they're a 2. Whatever the person I'm working with, my supervisor, I just go with it. I usually just ask for an explanation so I better understand how they're thinking. For your point of view, for exam point of view, for as you're starting, we're just going to give you some starting points to go with. But no, these are more grayish, not necessarily black and whitish. Not always right, not always wrong. There's some this in-between stuff based on people's experience and interpretation. Okay. Okay, hepatic disease. They have hepatitis, they have cirrhosis. I want to know that because what's important about the liver? The drugs we give, right? And you may have to change the amount you give or the types of drugs you give based on how well their liver is functioning. What about the endocrine system? Well, the number one thing I would say is diabetes because so many people are diabetic. Are they controlled or metformin? Or are they insulin dependent? That's important. They're always going to get a pre-op sugar taken before they go back in the OR. So you want to know what that is. So when you're doing your assessment, what was the pre-op sugar. You may have to go to the computer. There may be a little checklist on the chart where the pre-op nurse did it, and they write it there. This morning's blood sugar was this at this time. They'll go through their surgery or their procedure. If it's surgery and they go to PACU, they're going to do a second one after the fact, so you can compare. I'm not going to give you a scale of insulin you would give someone based on their sugar, because each site's a little bit different on how they do that. But for us, usually if the sugar is less than 200, we don't treat it. If it's over 200, we usually do treat it. How much do we give them as far as insulin? It depends. I would say 6 to 10 units of regular insulin, depending. Is that sub-Q, IV? Typically, we do it IV. It could be sub-Q also. Then we're going to recheck it. If it's a case that's going to last longer, we'll recheck it in an hour, intra-op, or we'll just check it again in PACU, depending on the length of stay. But when we talk about diabetes, insulin dependent or not, what's their AM sugar when they come in before the surgery, blood sugar, and then we're going to do it again after that. Thyroid disorders, rarely do I come across serious ones other than they're hyper or hypothyroid, and usually they're hypo and they're on some kind of supplement. So it's usually managed pretty well. Again, I'm doing elective surgeries most of the time. What would be some thyroid disorders that we're really going to be worried about? Okay. Anything else? Thyroid storm. Oh, anything really, like I'm concerned about hypothyroid, but if it's hyperthyroid, the stuff I do can really, really, really affect that and make it so you can get in a dangerous situation pretty quickly. So I want to know about those. If you aren't that familiar with some of these, just kind of look some of them up just so you have some in your head. Hypothyroidism is what I see all the time. Most of the time people are on supplements. I'm not usually worried about it in terms of my anesthetic management. I'm aware of it. But if it's hyperthyroid and it's not controlled, then that becomes a concern. So just look some of those up if you can't think of any. Neuro. I want to know how they came to me, but I must tell you, I do not do a head-to-toe neuro assessment. Stick your tongue out. Well, I have to do that just with the airway assessment. Wiggle their fingers and toes, lift their arms and legs. Now, if it's a neurosurgery, I'm doing a neurospine surgery, you better believe. I ask them, where's the numbness and tingling? Any in their hands or their arms? Is it just on the right, just on the left, just hands, just legs? That tells me a lot. And I want to know ahead of time, because in PACU, we're going to assess again. Is it the same? Is it different? Now, saying that, I may not be there long enough for they're fully awake where they can answer those questions for me. But the PA or the nurse practitioner that was with that neurosurgeon, they're going to do it. The PACU nurse is going to do it. So I want to know where they were ahead of time. And in report, I give that information to the PACU nurse. They had some numbness and tingling on the right hand, right arm. Before. So you want to know where they were, where they are. If they have had a stroke, anything that is residual that's still there, left side of weakness, right side of weakness, speaking problems, visual problems, ability to walk, I want to know that. If it's a TIA, again, any residual, and what is it? Do they have a history of seizures? Thank goodness in my NARC bag, I always have Versed. Benzodiazepine is what I'm probably going to give this person, right? And that's what I have handy, so that's probably what I'm going to give if I see seizures. Orthopedic. So many patients will say, like on our assessment sheet, it says RA. So rheumatoid arthritis, and they'll check it yes. But what they really mean is osteoarthritis. Two different things, two different sets of symptoms. So I try to clarify that with them before I go back. Because if it's rheumatoid arthritis, I'm really worried about the cervical spine and when I intubate. Really, really worried about it. And I want to know where, like somebody will say, yeah, I have RA and it happens right here, this knuckle. How's it doing today? Oh, it's okay. But what I'm really concerned about, really, is the neck. Now, there's other things to be concerned about there, but that's my immediate focus. So, arthritis, is it rheumatoid, is it osteo? Weaknesses, do they use an assistive device to walk? Do they use a wheelchair? They use one of those cool scooters. You can do wheelies on that stuff. Cane, walker. Do they use anything to help them? The walkers today, man, cool. They have a little basket on the front. They have a little handbrake. Like, I can't hardly wait to get there. I'm going to start with a 3-wheeler bike before I get there, hopefully. But we'll see. I already have it planned out. But you want to know those things before you take them back. Because if they were fully ambulatory beforehand, then afterwards they're not. Now, if they had a total knee or a total hip, okay, we get it. Because there's going to be a rehab involved. But you want to know that information ahead of time. If you need anything to help you walk around. I also want to again know about infectious disease. It really doesn't, with hepatitis, it might change our anesthesia plan. But these other two, HIV, AIDS, and MRSA, and that, we're supposed to treat everybody, like remember standard precautions, nursing 101, right? Every time you get a job somewhere, they always take you to that orientation, they talk about that. You just want to make sure that you have protective personal equipment, and we should be treating every patient like they are infectious, technically, right? So that we don't get it, so we don't pass it to anybody else. So you want to be aware of that. You want to pass it on in a report if you see in the chart that they're MRSA positive or whatever it is. E. coli, usually you can tell that one from ICU nurses know about that one. There's a, you know. MPO status, we argue sometimes, you know, and it does change through the course of time based on the best evidence that's out there. But right now, this is what we're going with. We say, I still say if I were doing the Preop assessment clinic education, you'll have to find out where you're working. But I would say, you know, MPO after midnight still. That's kind of how I do it. So that they know they shouldn't have anything to eat or drink. That being said, there may be some medicines we want them to take in the morning with a sip of water. What kind of medicines would those be? Blood pressure medicine, usually most of them, not all of them. Beta blocker would go in that category, yes, but it could be used for something else, sure. Do we want to take their insulin?
Half dose.
Sometimes no, sometimes half a dose, it depends. And those are the kind of people, the diabetic folks, we like to have earlier in the day, the first 1 or 2 cases of the day, so they don't have to be NPO all day long, because then we're contributing to this disease process because we can't really control it as well. So, clear liquids, 2 hours. Okay, let's talk about this. Starbucks chai latte. I don't know if you know what's in there. A bunch of heaven. It does have some sort of milk product. It has some kind of sweet something. If it has milk in it, if your coffee or tea has milk in it, is that a clear liquid? No. Thank you. Make sure you read your test questions very carefully. If someone had black coffee 4 hours before surgery, would we consider that to be safe under these guidelines? Black. Black coffee, it's not a racial thing, it is a, nothing is in it except the coffee and water and beans that it's made to make it, okay? Now, if we add mocha to it, if we add cream or milk, it's no longer black. Now let's talk about juices for a minute. We're going to be a diverse group because I saw that video you guys did was awesome. So we're going to be a diverse group. Is orange juice a clear liquid? Orange juice, clear liquid?
With or without pulp.
With or without pulp? Okay, that's Is orange juice with pulp a clear liquid?
No.
Is it without pulp?
No.
It's still not a clear liquid. So is orange juice a clear liquid now? Okay. What about Trop 50?
What? No. Drop water.
Trop, there's Tropical, it's called Trop 50 or something. Okay. Never mind. Apparently it's not high on your list of way to reduce calories in your life. Okay. Clear liquids, you know what they are. Water, black coffee, apple juice. Thank you. Is Jello a liquid? Yeah. It can be before you stick in the fridge and it gels. Okay. I'll accept that. But, okay, let's just take a vote. How many of you have had liquid Jello recently? How many of you have had liquid Jello in your lifetime? Okay, so, not that I know about these things, but Jello shots are still gelled, right? Except maybe sometimes the alcohol can't really absorb, so there's a little liquid around it. I don't know. Hopefully, your patients have not done 3 or 4 Jello shots before surgery. But if they did, it may change how much medication you give them for control.
Saving money, it's economic.
Now I see where we're at. I'm afraid to go to the next one. Breast milk, 4 hours. Formula, 6. Non-human milk, okay, it's coming from a cow or a goat mostly, probably, right? I can't.
Or sheep.
Yeah,
Does that include almond milk?
Yes, we're gonna say yes. A light meal. Now, that's not very well defined. 6 hours, we're gonna say. You had a question?
Yes, so just thinking about some patients and when we see one particular safety net hospital. So if they say they had a shot of vodka at 4 in the morning to calm their nerves and their surgery's at 6, is that considered okay for them?
Well, it is considered a clear liquid. But I would be concerned about anybody, hey, it's a legitimate question, because they may have already said, yeah, I took my Valium this morning, and you're thinking, good, I'm glad you did, because they're already like, and you're like, well, I'm glad you already had 1 dose, and it's probably already dissolved and in your system, and that's good. You know, I haven't had that happen to me knowingly, but I don't think it would be a showstopper. Now, you know how people, when you ask them about their social history, we consider alcohol as social history. I'm not sure why, because sometimes it's an addiction. However, their social history related to alcohol, you may be glad they took that drink. Because they say, well, I really haven't had, okay, they're an alcoholic, but they're not going to tell you that. Maybe they're an alcoholic. And so if they're in AA, they're going to tell you, you know, my name is Avon, and I'm an alcoholic. I'm not just kidding. So if you see me out in a, you know, at a social event for a UNF nap and I'm drinking, don't think I'm relapsed. I am not, just making an example. So a lot of people that are in recovery will tell you, and so you know, and so a lot of people that have been addicted to drugs too that are in recovery, regardless of what the drug of choice was, they're very concerned about going under anesthesia because they don't want to have a relapse. They don't want to be addicted. And you're going to do everything you can to keep that plan so that you can minimize narcotics but still take good care of them and reassure them. If they're on methadone, make sure they take their doses, that they've taken their doses. You want to make sure if someone is truly an alcoholic, but they said, oh, I stopped 2.5 days ago, haven't had a drink, and you're like, okay, now they're not only going to have to survive the surgery, now we got to deal with DTs. They're at higher risk for having problems. So I would never tell a patient to go ahead and have that shot of vodka in the morning.
Surgeon can order beverage of choice.
That's true. That would be past us, though. I would want to know chances are recovery. And is it a clear liquid? Yes. But it might affect your anesthetic plan. It might actually help it. I hate to say that out loud on recording, but depending on where they are in their disease process, if it truly is an addiction, it might actually be better in that respect. But I would never recommend it. Yes.
What are your thoughts on Valium?
Okay, good question. This is an excellent question for many reasons. Know the answer. Someone comes to the hospital, they've been MPO, but my mouth is so dry. So someone, this great, loving, kind nurse in the Preop holding area, decides they want to give one of those swabs, you know, use an IC, just, or they give them a piece of gum, or they give them a hard piece of candy, or they give them anything by mouth. They're at higher risk for aspiration. When you put something in there, guess what happens? Your body goes, oh, good, we're getting ready to eat, or we're just eating. And so guess what happens? All those juices, everything's going on. So you put them at high risk. That being said, we will still have people take it with a sip of water, their medicines, right? Right before. They might take Pepsi, they might take something. They might take some of those kinds of GERD controlling medicines. They'll take some of their blood pressure medicines, some of their heart medicines. We want them to do that. But gum, swabs, I get glycerin swabs is what they are, hard candies, those kinds of things, we really don't want to give them. For our textbook answers, we don't want to give them because it puts them at higher risk for aspiration. Please do not be judgmental if you go to a place that practices that on a regular basis. But when I made folks aware of that issue in our hospital, it stopped, and it stopped very quickly. Because there's other things we do that can put them at risk, right? Again, taking medicine with a sip of water. But that is preemptively the right thing to do because we have this kind of like risk versus benefit thing going on. I want their blood pressure controlled. I want their heartbeat to do what it's supposed to do, like keep beating throughout this procedure. But gum, hard candy, glycerin swabs.
I mean, but ultimately, it's up to the surgeon and the anesthesia provider. And
Yep.
My observation over the summer in assessment, I'm the one that the patient came in for dental surgery, so she was not going to have an anesthesia provider. They were just going to do the dental anesthesia. And so she had had full pulp orange juice before she came in, so within the last hour. And when I was doing her ASA, her Malinpie assessment, she had gum in her mouth. And the dentists were like, oh, that's okay, spit it out. And they went back to surgery.
So dental anesthesia can be local, or it can be general with nitrous and a tube and all that kind of stuff. So I don't know.
I asked them what they were using, and they said propofol and Versed.
Yeah. So I wouldn't recommend that. As an anesthesia provider, I would not ever recommend that. And if I had a choice and I was working, I would either have them change their practice, or I wouldn't want to work there myself, because I do think that puts the patient at high risk. Now, the chances of something bad happening are probably relatively low, but why would you want to increase the risk of a negative outcome when you have to tell them no gum, no whatever? So that would be my
So in
thought.
that instance, could they just give them like a little bit of glyco and then kind of blunt that like salivary response?
Well, salivation can relate to aspiration, but no. I would, if I was a dentist and I was having somebody come in for dental surgery or teeth extraction, or they were going to be going to sleep, and they usually use nitrous there a lot of times,
This
or
is at
a
UM.
propofol drip, and or they can take that responsibility if they want to, but I'm not going to take that responsibility. And again, a propofol drip, in my mind, is it MAC? Is it general? So how did I draw the line? And again, everybody's going to have their own opinion, but my opinion, based on my experience, if you have to support the airway in any way, that's a chin lift, jaw thrust, nasal trumpet, oral airway, that person would basically die without that assistance. That becomes what kind of anesthesia? If you can do a propofol drip, and you can get them in a place where they're just breathing spontaneously on their own and all is well, then, okay. Sometimes with dental surgery, they'll have them in sort of like a beach chair kind of position, as opposed to if you're supine, you're more likely to close off your airway. But if you're sitting up, then the tongue doesn't include the airway, so maybe that's there. But I am all about preventing aspiration as much as I possibly can. So now these are the numbers. 6 hours light meal. Still, some places use the old school method, NPO after midnight, period. If they come in and they need to have a gallbladder, a lap chole, gallbladder taken out, they'll say it has to be 8 hours. So you just really have to go by the protocol of where you're working. It's not the time to wave your flag and go, well, the best evidence says this. As your sRNA role, student, capital S, little r, little n, little a. You find out what the protocol is, ask the question, and follow their protocol. If something happens, it's on them. If you do it book or EBP, because that's what we think is best, you gotta go by the protocol where you're at, because sometimes it takes a while for places to catch up with all of it, usually like 10 years. But, yeah, so for our test purposes, this, in a clinical setting, you gotta find out. When we talk about medical history, 3 main rules. They're acute history, and again, I can't emphasize how important exercise tolerance is. History of present illness, what are we doing for it? What's the last time I saw their primary care provider? Or if they have heart issues, when's the last time I saw their heart guy? If they have respiratory issues where they go see a pulmonologist, when's the last time they saw that person? I say guy, I mean men and women. I grew up in Illinois. So, why are they here? What's the acute thing going on? Number 1. Number 2, what's the chronic? What do they have? What do they come with? The comorbidities that they come with. Not only medications and allergies, and is it a true allergy or not? That's why, the reason you want to know is because what are you going to give them or not? And social history, I love this, ETOH and smoking. So let's be social, let's drink and smoke. And if you're in Colorado, oh, never mind. Do they drink? How much do they drink? Typically, if someone says, oh yeah, I have 1 or 2 drinks on the weekend, social, okay. Someone says, yeah, I have like 4 or 5 drinks a day. It's probably like, yeah, I don't know, 6-pack. I had someone that was honest and said, yeah, I have 12 beers a day. And I'm like, what? In my head, like, does your wife like to do that? Is she there? No. So, just kidding. Where are they at with this? The fact that somebody drinks may or may not make them high risk. But if there's someone that drinks regularly, they could be addicted, they may not be addicted. That's not the time. We're not trying to diagnose that. We just are trying to diagnose how is it going to affect our anesthesia plan. Okay, so no judgment here. Someone smokes pot, someone uses cocaine, someone does meth, I don't know, whatever the drugs are that are available out there that people like and enjoy for recreational use. I want to have an idea of what they're using in a non-judgment zone. I'm not going to turn them into the police. I just want to take safe care of them. So it's important that people answer that honestly, if they can. Most people won't. So in the Army, the answer to my question is, do you drink? The answer is yes, I do drink alcohol. And the correct answer is I never drink more than 2 on any one occasion. You know this, right? I never drink any more than 2 on any one occasion, because if I do, it puts me in this whole other checklist, and then, oh, I got to go see a specialist, and I go, well, we will do it. Now, I get away with that with my honest and true heart, because I can say how long, they don't define what an occasion is. Now, is an occasion every 30 minutes? Every hour? Every hour? Every 15 minutes? Every 2 minutes? I don't know. But when you're assessing your patients, you may or may not get honest answers. Someone says, I drink 3 drinks a day, maybe 6. So just know, when you ask about drug use and or alcohol or smoking, I quit this morning, or I quit yesterday, or I quit last week. And then, but they smell like smoke. Okay, I don't know. It may just be residual, it's been absorbed because they've been smoking. But take them at their word, but in your head go, I'm aware of this, I may need to make some changes. Now, if they quit smoking 20 years ago, their lungs are probably in pretty good shape, unless they already have emphysema or COPD or something like that. And that would probably change how you take care of them, or you're going to be more on alert for respiratory issues. And again, we talked a little bit about family history. Past medical history, have to know past surgical history. Any problems with anesthesia in the past? I've never had it. If they've never had it, then I say, would you like me to explain things more thoroughly to you? Because I want them to know. And they're like, yeah, that'll help me out, thanks. Before I give them medicine, I don't just go, they're like, ah! I go, I'm going to give you some medicine now. You may notice a sensation in your IV. I don't go, it's going to hurt like Hades, because it might if you give them propofol, but I will just say, and you might feel a warm sensation. Now, they might say, it hurts. What do you mean warm? It hurts like heck. And I'm like, yeah, it may hurt that way, but just for a short moment. But I don't tell them, this might hurt really bad. Because some people have a reaction where it really hurts and some people do not. So I want to give them the mental idea that they may notice something, that it's normal, and it will go away quickly. Because they'll be here tonight. That's the bonus. The third rule, physical exam. You've got to get good at this, and you should be practicing with your family, friends, and neighbors. Right? You should have already done at least 20 airway exams. I hope you know at least 20 people. If not, go door to door. Make a little sign. I'm an anesthesia student at the University of North Florida. No, don't identify yourself. I'm doing airway exams. Can you have everybody in your family line up in the front of the house in the next 5 minutes? Okay. Take your stethoscope too so you can do heart and lung exams as well. You should be pretty good with heart and lung exams from your ICU experience. When you do lung exam, upper, lower, and it can be here on the side or it can be in the back, however you want. What are we listening for? Anything or nothing. Diminished sounds, crackles, wheezes. If somebody is wheezy, or it sounds like they have fluid in their lungs, we may have to postpone their surgery until they get a respiratory treatment if it's wheezy. And then afterwards we listen again, it sounds clear, okay, we're good to go. And you'll probably want to write for a respiratory treatment in your PACU orders after the fact in case they need it again. Airway exam, you should be experts. And if you have not been looking at everybody you know, hi, my name is Dave Ron, open your mouth. I was a little more subtle. I'd have people over, give them a drink first and then say. So, as many airway exams as you can, mouth opening, TM distance, what you see on the inside. You have plenty of friends that probably have ASA 1, 2, and 3s. I shouldn't say, I mean Malampati, excuse me. So, look at the diversity. Some people have little mouths, some people have big mouths, some people have little tongues, big tongues. What's all going on in there? They'll say, yes, you can, but let me brush my teeth first. That's fair. That's fair. Heart sounds, you're probably not going to diagnose a murmur and all the different levels and stages of murmurs. But you want to know, is it a fast beat? Is it a slow beat? Is it a normal beat? Do you hear a murmur of any type? And was that noted in the chart somewhere, if you do hear a murmur? Are they in sinus rhythm, sinus brady, sinus tach, because maybe they're febrile, maybe they're volume depleted? Are they in AFib? I charted on a person the other day, sinus rhythm, and I'm like, they were AFib and Preop. And I had to go back and, draw the line through it and go, AFib. Because I mischarted. Now, it was a silly mistake. Thank goodness I caught it. But you could see if there were a negative outcome in that case, and I didn't catch that mistake, that let's say we're in the courtroom and they're going, well, how do we know anything else is true on here because you put sinus rhythm the whole time and they came to you with AFib. Like, I did not have a defense to stand on anymore, right? I mean, stand on a fence, falling back, going to jail. Well, probably not. They just take all my time. All right. You must be good at an airway exam. You must be good. Everybody gets a heart and lung before they go back. Listen to lung sounds. Listen to heart sounds. The 3 rules: acute assessment or acute history, chronic history, and a physical exam. For anesthesia, it comes down to this. You may have to do some other physical exam stuff, but you've got to do this, and you have to chart it. You have to have that conversation. Okay, you should know these. Hasn't changed. These are, it's actually ASA physical classification. So ASA 6, brain dead person that we're going to harvest the organs. I've given you some examples here. CHF, renal failure, ASA 4. Ruptured AAA, ASA 5. Severe systemic disease that limits their activity, ASA 3s. Okay, so how do we know if someone's in CHF right now? ICU people. Wet lungs, okay, with a stethoscope, maybe.
Without?
With a stethoscope, with. How do you know it's heart failure? Listening to heart, listening to lungs? Oh, what I hear? What is JVD? Okay, so what does that mean? You see jugular, it means fluid's backing up, right? Which means they might be in heart failure, right? And what would you hear? Auscultate heart sounds. Has Dr. Pavlotti gone over some of the heart sounds and stuff with you? I don't know. I know he's doing EKG for. Okay, so there's an S1 and an S2 sound, right? Remember S1, 2, and 3, 4? Okay, remember, yeah, okay. If you don't remember that, just kind of do a quick review, Google it, whatever. Normal would be lub-dub, S1, S2, beep, 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 okay? If they have an S3 sound, what is it indicative of? Along with JVD. Now, you may not diagnose it, but if you see that, they're at very high risk for having problems in trial. That is significant. And we may have to cancel the surgery till we pull some fluid off, till we can help get that CHF under control. If someone comes to you with, in the midst of a heart attack, we're probably going to get that under control if they survive it, because the number one symptom of a heart attack is 50% of the people die. The 50% of the people that survive are probably not best candidates to have surgery right this moment. We're going to want to medically treat that. You should know these. This is just to give you an idea. So mortality rates, and these are old, this is old data. But if someone is healthy, they have a very low risk of having a problem with anesthesia, right? But if someone is an ASA 4 or 5, 25 to 50% chance they're not going to make it. So that's where you have that sphincter factor with your extra set of scrubs for the case after, two set of bottoms for the case. You can see that ASA 1s and 2s, pretty low risk. ASA 3, it's increased, but it's reasonable. When I say reasonable, compared to 25 and 50%. So ASA 45. GYN exam is not part of your anesthesia assessment. This is a Dr. McDonough slide, I just had to keep it because somehow I just thought it was awesome. Oh, Lord. Okay, physical exam. You want to know what their vital signs are before you go back? And then when the first thing you do once you get them hooked up on the monitors before you induce a patient is a set of vital signs. You've already done airway exam, physical exam. Mouth opening, you should know this by heart. What's the number we want? 3 what? Or FB for short, right? Finger rest. So if you see that somewhere in the future, you'll know what FB stands for. Future brainiacs. Nope. Oh, now we'll talk a little bit about teeth as well. You should, the ones I know, 8, 9, 24, 25. These and these. Why? Why? Because that's where all of the anesthesia payments go. For 8, 9, and 24, and 25, when you damage those teeth. Yeah. What is jaw subluxation? What's that mean? Taking bottom. Now, if someone can't do that, they're higher risk for difficult airway. If someone has TMJ and they can only open their mouth like this is mouth opening, right? You're like, wow. Sometimes, after induction, they will have a larger opening, but you have to have a plan for what you see in Preop. So I'm going to have some kind of assistive device in there. I might even have the difficult airway cart right there by me, because if their mouth opening is like tiny, that's going to be a concern for you real quickly. But again, sometimes once you induce, you may do your scissors to open the mouth, and it may need to be more than you think it's going to be, or sometimes it's just fixed. You have to have a plan and a backup plan for that. Range of motion becomes important, and you want to know all the ways the neck can move. If they're coming in for a surgical, like an ACDF, surgical surgery, then they may not have much range of motion, so it would be limited. And so you're also thinking, I'm probably going to use some kind of assistive device so I can keep their head in line so I'm not causing any extra issues or problems. Something that sometimes I think will be a big problem initially till you get more experience is getting a good seal on the mask. Because Our adult faces come in all kinds of shapes and sizes, and there's basically one mask size. So, anyone that has facial hair, notice I didn't say men with facial hair. Anyone that has a bunch of facial hair, it's harder to get a good seal. And the finesse of being able to adequately get a good mask seal and ventilate patients, that is a skill. You can never get too much of that. Matter of fact, on your typhon records, one of the things you have to do is have so many mask management cases. And it's kind of a, I'm trying to think of the politically correct word to use. It's kind of a hassle to do it, but that is a skill you want to master. You've got to master that. Remember we used the EC technique when you're holding the mask. These three fingers kind of go on the jaw, and the C holds the mask down. Sometimes you can get a good seal, but you have to think about too, you may have to move the neck back, but what if they have a problem with their neck and you can't? Then you have to have someone, sometimes I have to have someone do a jaw thrust while I hold the mask with the other hand and I ventilate. It doesn't mean I'm not a good anesthesia provider because I need assistance. It means I'm a good anesthesia provider because I know I need assistance. I need 2 more arms, 2 more hands. Make sure you know this real well. Oh, there we go. Should be 3. And these lovely, yucky pictures. This, you can see everything. This, all we see is what? What do we see in 3? You won't miss that again if you happen to see it, right? Then be able to differentiate between these. What's the difference between 1 and 2? Tonsil pillars, okay. So make sure those are the bad, ugly pictures you'll be seeing. All right? There we go. Only hard palate. Hard and some soft. Now I can see the base of the uvula. Sometimes you do, sometimes you don't. But I can see hard and soft palate. We need a picture of Gene Simmons doing that. Okay, this would have been useful for the last exam, wouldn't it? If someone is a class 1, Malapati class 1, then the view, a lot of times, is grade 1 when you do your DH. If somebody has a class 4 view, and remember what is that? Hard and soft palate, right? Oh no. No. What is it? If it's a 4, it's hard palate only. Okay. No tricks involved here. If it's a class 4 view, the grade is usually 3 or 4, almost all the time. But this is comforting. Malapati class alone may fail to predict 50% of the difficult intubations. What? So you're doing the best you can with what you've got, and you make your plan based on that. But no, even in your best assessment, it may or may not be right. It may not be. It may by right. I mean, they may be an easy intubation. They may be a difficult intubation 50% of the time. Okay, here's number 8 and 9. 24, 25. Save your money. That's where your money will go. Paying for UT. I like that one. I don't know if that's real or if that was just kind of made. I don't know the answer to that question, but that's real. Who is it? Somebody in class?
I just figured that out.
Oh.
Yeah, what's the point?
Ooh.
I think that's for stimulation.
Were you able to like take like wax strips and put it on people's teeth?
I hear discussion about the purpose of this. That is beyond the scope of this class. Oh boy. So yesterday, I took care of a 16-year-old that had a clavicle fracture, so we did an RRF of that. And he was like I don't know, I thought his BMI was like 35, but he was just a big, solid guy. So he really wasn't obese, he was just big. But he had braces. And he had a little baby face. So he had this kind of manly, grown-up body, but he just was like a little kid. And on the inside, he was there with his mom, and I'm like, oh, this is so cute. Reminded me of when I used to teach middle school, like those 8th graders, like they're close, but not quite there. So he had braces on. Now, when anyone has braces, first of all, if they have partials or dentures, they come out. Almost all the time. There are occasions we keep them in. Rare. We take them out usually, and they put them in a cup, and they give them to the family, so we're not responsible for replacing those, as well as, any teeth we did knock out. We don't want to have to do that. So braces can, when you do a mask, or when you insert an oral airway, or you do a scissors, remember, if you press on that, they can get you can hurt the mucous membranes. And that happens on a good day with people, if you have braces, you know what that world is like. They put wax on it usually and stuff. They may or may not have them waxed up to help protect them for surgery, but if I were doing a pre-op assessment with somebody that had braces, I'd say, make sure you wax those up, and let them know, because it can also hurt the inside. You know how when you get a sore in the inside of your mouth because of your braces? We want to prevent that, because you're at higher risk for having that happen when we do anesthesia. Just let them know. That way they can prepare for it. And I checked his lips as soon as he went to sleep. I flipped them up and flipped them down again. They were in good shape, and then after the case, I flipped them up and flipped them. I go, okay, good. We didn't cause any problem. But I let him know ahead of time, and his mom, that was a risk, and it could happen. So if they did see it, they didn't think I was trying to beat him up, but just because he has braces, it puts him at risk for having some of that mucous membrane skin tears and stuff. Now, did the SRNA I worked with last week do this, or did the patient come to me that way? You need to chart teeth. Missing teeth, loose teeth, cracked teeth, dentures, partials, because anesthesia is going to be held accountable. There's probably been more than one patient in the past that knew this somehow, and they have a nice set of teeth now because we had to fund it because we didn't chart it appropriately. So make sure you chart it. Yeah, I kind of like that one. All right. We know this, TM distance. Oh, trying to put a mask on this. The mouth and the nose is covered, right? Where's the air going to get in? Yeah, through the ears and through the eyes. I like it. He would be hard, this patient would be hard, not only because of the beard, but just because of the BMI that's just so big. So when I have a patient that's got a large head, big neck, short neck, I always get an extra pair of anesthesia hands before I induce. Because I know I'm going to need help with that. I have little hands. For a wide hip person, I have little bitty hands. That's just not right. That's the way God made me, though, and I'm grateful for it. But when I have a situation like this, I'm going to need some help. I'll tell the OR nurses what I'm going to need you to do, what I need you to do. I'm going to talk to my ologist ahead of time and say, listen, I'm not going to push the protocol till you get in there because I'm going to need a second pair of hands. Now, I'm going to have a lot of things going on with this person. I'm going to ramp the bed. I'm probably going to put a little reverse Trendelenburg to back up a little bit. And I'm going to wait until I have help. I might already have the difficult airway card in there. I'm already going to be using a glide scope or CMAC and the big blade, the one that goes a little further, a little longer, because I'm going to need that distance.
Do you guys here do awake intubation? Right?
We do sometimes awake intubations, and that would probably be, depending on what else is going on with this person, that would be a great answer. What do you guys do?
We don't have BMIs of 110.
So, all we have to do, that is a true answer. All we have to do is be moved to Europe and there will be no problems.
We do have fed before, but 110?
Wow. That's why shows like The Biggest Loser are important. I don't think it's on anymore. But, so, the answer to your question is yes. Some folks will just say, okay, here's what we're going to do. We'll wait the fiber optic with this stuff. Yep. It really just depends. That would be the best and safest answer. All right, range of motion. This is the picture you want to see when you do your DL. Sometimes you will, sometimes you won't. Remember, we've got these bones here, and then you've got a couple down here. Just make sure you know what they are. Some people will refer to them as the the arytenoid cartilages, but they do have specific names, cuneiform and carniculates. We have the false chords here, the true chords here. What's this in here?
Aperture.
The aperture or glottis, the opening, but then further in, what is that?
Tracheal ring.
It is a trachea, and you can sort of see, not too well, tracheal ring. Remember we talked about putting the bougie in, and when you put the bougie in, you feel that. That means I'm hitting those, I'm like, I know I'm in the right place. If it's smooth when I put it in, I'm like, well, I'm probably in the esophagus. Yeah. Don't want that. Make sure you know the Cormack-Lehane grading scale. Most of the people I see, what I will see and what you might see as you're learning could be very different. You may see a 3, and then I go and I do 2 little adjustments, and I go, grade 1, see? Okay. Positioning is everything. Because remember those 3 axes we're trying to line up? Know those. And if they're over or under aligned, it can make a difference on the grade you get. If the patient's ramped, if they're in a good sniffing position, if your skill of intubating with either the Miller or the Mac blade, all of those things make a difference in what you see. And here are the best, worst pictures that we'll have on an exam maybe, and I'll have you identify them. What is this, grade 4? What kind of view do we have? Nothing. What about grade 3? A little bit of the epiglottis, a little bit. Now, notice the difference between this picture and this picture. Okay? This is supposed to be an epiglottis. This is not an epiglottis. All right. The rest I think you can get. But same bad pictures here, same bad pictures on the exam. As far as labs, what do you need to know? You need to know everything. If you don't remember normal values of labs, go back and review that. Now, I don't know that I have them all memorized anymore because, you know, I have the cheat sheet. On the sheet, it'll say, here's the normal range. Now, there's certain ones that I really know and I know by heart because I use them every day, all the time. So H and H I want to know. Every day, all the time, I have to chart it, so I know that. If someone is on dialysis, what lab, if you had to pick one, what lab would you want to know before you take them back? Creatinine? No.
Potassium.
Okay, let's all say it again with a K. No. Potassium. Okay. So potassium is what we want to know. It needs to be in normal range, and it should be after dialysis. Sometimes that's a showstopper. So if you have someone that's on dialysis before surgery, you must have a potassium value. Anyone that's diabetic, you have to have before we go to surgery, you have to have glucose. Those are the only ones that I can think of right off the top of my head. There are others. You gotta know that. If someone has a cardiac history, we're gonna look at EKGs, chest x-rays with respiratory issues, or if they have central lines already placed, those will be on the chart. Different facilities will have different protocols about what's required, what labs, what procedures are required before surgery. Now, it depends on the surgery you're having. It depends on what comorbidities the patient has. And you have to find out at each facility what they're requiring. When do you do an HCG? Well, that's a great question. How old? What age? Is it start at 10? 11, 12? And how far does it go? 50, 55? You'll have to ask that question where you worked. For us, I think, unless they've changed it recently, which I say recently, I was gone 5 months in the Army, so they could have changed it and I never knew. It was like 12 till like 55. Some places it goes to 50, some places it goes to 15, 50. That age on the young side keeps getting pushed back.
Do they have to have the minority?
Usually, yes.
So if the 12-year-old did not?
If they did not, then we wouldn't do it. In our place. All right. This is how how you can write them if you're writing notes, but a lot of times now everything's on the computer, so we have our paper sheet, so I would write these in here, depending on the patient. I don't write normal labs down. Anything abnormal or anything I need to address, I certainly write down. That being said, if someone is on dialysis, I always write the potassium down. If someone a female is within pregnancy range, I write HCG negative. If someone was anemic, I might write their HH. If they're diabetic, I'm going to write their fasting blood glucose. Here's what we're doing. Building the relationship, looking at their medical history, why are they here, what brings them in today, coming up with an anesthesia plan once we've assessed them. We talk to them about it, we educate them, talk about options and risks, then we get their informed consent. All right, nothing new here. Something I want to remind you of as you go to the hospital, even at St. Vincent's tomorrow or at Preop Health this evening. HIPAA, HIPAA, HIPAA. If you cannot write down patient names and take it out of the hospital. You can't do that. You can put initials and what they had done and how old they are. You can do that kind of stuff. Nothing identifiable. 58-year-old male you can do. Usually even initials are not considered okay. But I know you're going to have some information. You're going to have a way to record it to put it in your typing, right? So some people have stuff in their phone. Some people have a little notebook they write it all down. Most people I see writing it actually down. You don't have to have names. There should be not any kind of personal identifiable information on that ever. Some places when you go to your clinicals are going to give you a printed schedule. It's got everything you want on it. Some of them don't. You're going to use that to write your notes on about the patient. That should not leave the hospital. Now, if you have a place you can put your typing stuff in on your phone or at a computer at the hospital, you can do that and then toss it. Usually there's a place to put shredded material in the hospital, find out where that is. Most of the time that stuff should not be leaving the hospital, okay? So you know. I don't want you to get in trouble anywhere. If somebody gives you one of those schedules, it shouldn't, and you still need it for your typing or whatever, then you got to figure out how to put it in a second place in code without personal identifiable information. And most of you are signing an agreement, a confidentiality agreement at the places you're going to. For St. Vincent people, there's an orientation packet. You should read through that. There's a post-test, all about safety kinds of stuff, and then there's a couple of places you have to sign, and that's why you have to send to me. All right, fast and furious. I will send you information about what to focus on the cardiac aspect of assessments, and it will be some, but not a big whole bunch. But make sure whatever I say, please review it. Because I'd rather have you review it ahead of time, and then I can say, well, did you review what I said to review? And you go, no, ma'am. Well, that's why you missed those 5 questions. Okay, sorry about that. But that's on you. I want to set you up for success. That's my goal. That's my purpose of being here. So I try to make sure I emphasize the things that are going to be most important for you right now. You're going to have to know it all, right? But we'll take small steps and build on this. Next semester, it's more like it's a faster pace for us. Questions about this lecture? No. Yes.
This isn't about lecture.
Okay.
For our observation days, do we need to get our preceptee to fill out an evaluation form?
Good question. And since we have a couple minutes before whoever comes in next is coming in, is that Dr. Self or Shores? I should know the schedule, right? But those guys always change around all the time. Anyway, so you will have a evaluation, even though you're observing. Just basically, they sign it to say you were there. This is considered observation. In some places, it's observation only. In some places, it's modified where you can have some true patient hands-on contact. You will let the place you go to dictate that for you. But for each day you go, you should have a evaluation sheet that they sign. Okay? Can you find that information?
Yes.
Is there one in the, did I put one in the actual class? If not, it's on Nap Central. There's one in there for practicum 1. You should be able to find it So print out, I would print out 3, just in case you mess one up. And really for this purpose, for this class right now, the purpose is for you to be in the environment, and now you're in school, right? You're in anesthesia school, the moment you've been waiting for. You've all probably job shadowed, I'm sure, before. But now you're like, this is me, next semester, 2 days a week. You're gonna be observing like the flow, their routines, their checklists. Watch what they do and try not to get too overwhelmed because you will get there. I remember watching going, there's no way I'm going to be able to remember everything I need to know to keep this patient safe within 30 seconds or less, right? We all feel that way. But try to use this observation time. Observation skills, like the best scientists that you're probably started at 3rd grade, elementary school, science teacher taught you all the way through middle school, because I know I used to teach life science in middle school. Those observation skills, use them to help you so that you're going to feel prepared come January. Whew. Now, we probably don't usually start clinicals the first month of January. Usually it starts, I'm going to say February. But you'll be hitting the floor running next semester. So this is meant for you to be there, observe. If you're fortunate enough to get some hands-on, great. But if you don't get to touch one patient ever, you don't get to slip an LMA in, you don't get to do a DL, I know you're going to be disappointed. Try not to be. You are going to have plenty of time and experience. And it's okay to compare with what you guys do, but try not to get disappointed if your buddy got to do like, wow, everything, and you didn't really get to do it. You were like this, kind of observing. Either way, make it your best possible experience. It's on you to do that. Does that make sense to you? Yes, you must have 2 evals. They need to be signed. And what I suggest on the eval, probably this person will say, just observe today. Okay, fine. But if I were you, I would detail on each one what you saw, what you did. There's a place on comments under there. There's a place on the checklist where they say satisfactory, needs experience, unsatisfactory. You don't have to check those. But in the comment columns, you can say, I placed LMA there. You see, we had 3 LMA cases, we had 2 DLs, we had kind of explain it so you can remember what that experience is. And it gets you in good practice for filling out your evals in the future. The preceptor is responsible for signing it, and sometimes they put comments, then they usually fill out the checks, satisfactory, unsatisfactory, or needs experience, needs improvement. They will check that out. And if they say needs experience or needs improvement, they will probably write a note to say what you need. Sometimes there's a phone call, conversation, or email between you and that person. It's lovely. And I try to remind your preceptors that, yes, you've been doing this for 10, 15, 20, 30, 40 years in some cases, and this is like your first semester of anesthesia school. Come January when you're actually doing clinicals. And sometimes it's just hard for them because they just expect you to already be there. That's okay. I take that into account when I'm looking at your evals, and I'm getting this challenging eval based on the preceptor you're with. I get it, and I get all these preceptors from all these sites all the time, and I look at them, so I know what preceptors are like. Oh, I almost said that word. Okay, some preceptors are really tough on you guys, and I know that. Some of them will write the whole page and then turn it over on the back and write the whole page and then want to add another page. And I know who those people are because they do it with everybody, every time. It's okay. For this experience, 2 evals, the preceptor needs to sign it. That tells me you were there, because I'm not going to be at each clinical site each day with each of you. And then I would add some, if they didn't add any details, I would write details about what you did. Remember, your name has to be on it, the preceptor's name. Once you know your preceptor, you can print it up there for me. If I can't read it, it's kind of like if you didn't document it, it wasn't done. If I can't read it, I can't give you a grade for it. Like, I don't even know what. You should have a date. You should have this clinical site. It's okay to abbreviate, Halifax is kind of hard to abbreviate, but you can say for St. Vincent's SVR. No, stands for St. Vincent's Riverside. Flagler, write out Flagler and Halifax. Make sure it's legible, okay? And then there's a place, there'll be a place for like the types of cases you did. So be as descriptive as you can. You just say ortho. Okay. Was it hands? Was it feet? Was it neural spine? Was it total knees, total hips? So give me an idea of what you saw, what you participated in. And then I can recreate that picture in my mind when I'm looking through these to give you a grade and go, yes, that's what they did that day. Awesome, I'm glad they had that experience. If you just have the date, the time, the place, the person's signature, I'm like, and you maybe put general. Okay, that narrows it down, right? Were they lat choles? Were they lat appies? Those are different things, and I know that there are different experiences and different preparations for those. Was it a big belly case? Was it a resection? So also, if you put that on your evals, you should get one every day at the end of the day. That will help you with your typhon. And then you will be submitting those to me. You'll have a cover sheet that says, these are the days I work, this is the place I work, these are the types of cases, this is the preceptor I had. So that is where I get, it's like a Word doc you'll make. Different people have different ones, but you can talk to your mentors, they'll get you lined up with that. First page, then you're gonna have, in this semester, you'll have 2 evals behind it. You're gonna scan them, you're gonna send them, we're gonna put them in your Canvas course, and then I get to read them. Now, make sure they're legible. So sometimes I get them where like, I have to turn, I'm like, okay, if I have to do that for like 27 people, let me just tell you how much extra time that takes and how frustrating it is for me because I want to give everybody the A you deserve. Make sure they're legible. Make sure when you put them in, when you scan them and send them, they're readable. So I can't read it. That's one of the first, you're going to see a point missing, and you're going to go, I did it, I got it in on time. And I'm going to go, yeah, but I couldn't read it, so you're like, I didn't even accepted it. Thank you, ma'am. I am not hard about it. All I'm saying is, if I can't, if you don't make it easy for me, it really is, it's really difficult. So something that should take me, I'm going to say, just looking at those might take 4 or 5 hours for me with a class this size, because there's only 2. To adequately evaluate those. And because they're not in or submitted in a way that they're readable, it might take me 6, 8, 10 hours to do it. Now, I love you guys, and I do get paid for my job, but you can see where that would make me frustrated over time, and that it somehow could be a reflection in your grade if you don't have it neat, if you don't have it in on time, if it's not readable. Make sense? It's not a punishment. It's like I'm expecting it to be professionally done. And I am pretty lenient initially because, you know, there's a learning curve involved. Good question about that. What else can I tell you about that? Typhon is up. Make sure you're in there and just kind of peruse it right now. As far as Typhon goes, I'll just take a couple minutes to talk about that. I didn't prepare for this, so I could miss something. So you're going to have your cases listed in there. And you're going to have the types of cases. It's going to ask you ASA classification. It's going to ask you, you know, was it a regional case? Was it a general case? Was it an OB case? It's going to ask you all those kinds of questions. You're just going to click on it. For this term, hear this. You're going to put the information in, but the cases do not count. The cases don't count. Do the cases count this semester? No. If you do that, you can expect at least a point deduction. All right? Because I'm telling you now. With that being said, you probably get a nice, I was going to say nasty, probably get a nice email from me. Because that email from me has got to be a good one, I'm sure. So I will communicate with you and say, hey, you forgot. It's learning. This semester is really about learning. Okay? So please don't feel like your grade's going to be in jeopardy because of how you do this. This is how you learn it this semester and really next semester. But I do take points off because how else do I grade you for that? For these observation days, you show up, you're dressed appropriately, you're on time, you have your eval, you get it signed, you start putting that information in Typhon. Do the cases count this semester? No. Thank you. If you do that. Oh, yes. Is it a pet peeve? I don't know. We'll see. So I can think of, you're going to have care plans. You're going to have 3. And we'll talk more about this either today, maybe not today, maybe next week. 3 care plans. 1 general case, 1 regional, 1 MAC. Now, that being said, if you observe a case that's like a propofol drip kind of thing and they had to insert an airway, or they had to, so we would cross over to general, I'm okay if you want to use that one as a MAC case. But you can also say in the comments area, this can also be considered a general case because they had to support the airway, we had to use a nasal trumpet or oral airway. Because you may see some of those, and I'm going to let that count as your MAC case as long as you put a descriptor on there that tells me you understand there could be a difference, okay? And plus, where you go, they may call them MAC cases. And then I'll go, no. Yes, ma'am. Yes, sir. Whatever you say. Clinicals, 80% is your attitude, 20% of your skills at this stage in your career. 80% is your attitude and your approach, 20% are your skills. Now at the end, you're going to be judged based on 80% is going to be your skills, 20% is going to be attitude. That if you want me to write you a letter of recommendation to be my colleague, my peer in employment where you actually get a paycheck for this, you better have that 20% attitude. Or I'm going to say, you know what, I don't think they're a good fit for our group. When they all come to me and say, hey, should we hire this person? They're getting ready to graduate, they've applied, they're in your program, you know them well. I can talk about your academic. Did you work hard? I don't talk about whether you passed or failed an exam. I talk about, were you here? Were you on time? Did you have a good attitude? Did you work hard? Did you help your peers? Were you a team player? Did you bitch? Oh, excuse me. Did you complain? Did you make it more difficult for everybody, your peers and your faculty? Are you a person that represents the university and yourself well in this profession? Did you show up on time? Did you give it your all? Were you as prepared as you could be? Did you have a positive attitude? Did you work hard? Yes, 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 yes! I'll write you a letter of recommendation because you're that person. Did you just barely pass the boards by the exact number you need? Who cares? You're a CRNA. Whether you made 100% on it or whether you passed the exact number that you need. CRNA, baby, doesn't matter. And I was probably the one that got just the number to make it. So, you're going to be okay. And this flux that we've had this semester, we apologize. But it is not going to slow you down in the long haul. Okay? Whether we end up at UF Health forever or whether we end up at other places, you got to go. Don't lose sight of that goal in the weeds of the details. Now I know you do, because right now the details are all you have to hold. But we're going to get through this all together. Myself and my responsibility I take very seriously. I'm here because I like you guys. I want to teach. It is so gratifying for me to know that you are where you are today. And in 5 years, I'm the one that needs the lab collie, and I see your face, and I can go, oh, I'm so glad it's you. I know you're going to be taking good care of me because I know what you went through to get here. That's what I'm expecting. A lot of time between now and then. Any other questions about, let's say, first tomorrow? It's going to be fun. No stress, no pressure, but if you don't come dressed for it, I will probably call you out. I'll do it in some teasing, ornery way. My father taught me that technique. But I'll probably make fun of you. And maybe again in class the next week or something, too. Just so you know. If you're late, don't stress yourself. Bless you. Drive safely. Get there when you can. And then we'll have somebody looking for you, but just report to the main lobby regardless of what time you get there. I don't think I've ever had anybody be late, but just telling you, I'm giving you a backup plan, make you feel good. If you're late, get there safely, we'll find you, okay? The reason that comes to my mind is because this Tuesday, Wednesday morning, Tuesdays I have a class in St. Augustine, my spouse and I are doing it together. Don't worry, it's not divorce therapy or anything. But so we have this class we go to related to our church activities, and so we're there, and we both work in Jacksonville. Get off around 5-ish. Have to get to St. Augustine, and you're seeing the traffic pattern here because you guys know, right? So it's always kind of stressful to get there on time. It starts at 7, But if you leave it, you know how OR is, you get out at 5-ish, 5:30-ish, 6-ish, well, I'm trying to get to class on time, like you guys do. And I get there, great. Don't get to bed till, I don't know, 9:30, 10. And it's a short night because I have to get up like 4 o'clock in order to get to work on time. So I get up early, take my shower, get ready. On the road, did you hear about that accident with the big hazardous spill on 95 between?
Oh, yeah. We're on I-95 for 4 hours.
God bless you. All I can say. Fortunately, every day I go to work, every day I've been going to the OR as either an SRNA or CRNA, 12, 13, 14 years, whatever it's been. I've always planned double the time to get to where I need to be. Always planned to get there early and then double time that. I got to work, I had a 6:30 start, got there at 6:20. I had me work with a student. She had everything set up. I'd already called to say, listen, I might be late because I'm stuck in this traffic. And a ride that normally takes about 45, 15 minutes took me about an hour and a half. But then I already planned for that, right? Because 45 minutes is my normal drive. I planned for an hour and a half. Got there. It all worked out. Perfect. So always be early, which means you're on time. And you can plan for any of those things. You can't predict accidents on the highway, but you can always plan to get there early, be prepared, be on time the best you can. And then know what the protocol is if you're not going to be there. Saturday, tomorrow, if you're not there, well, I'm going to have somebody in class text you, just make sure you're okay. Okay? Because I want to make sure you're okay. Hi, Dr. McDonough.
Guten Morgen.
To you as well.
There you are. Welcome.
Thank you.
Not too bad. So, what do you think?
I'm having fun.
Oh, I'm so goddamn thrilled that you're having fun. I live so that you can have fun. I haven't had the pleasure to meet you when I was at AFC before. Not there.
I was not there, no.
No, but I have occasionally shown up there. Welcome.
Thank you.
Does anything, I'm sorry I hadn't had a chance to meet with you earlier, but it's been crazy this week for me. So, anything we can do to make your stay more meaningful, by all means, ask them. They will make it so. I would have hoped to have brought you out sailing, but unfortunately the last hurricane moved a building behind my boat, which I've trapped.
No.
So it'll be another couple of weeks of no sailing, unfortunately. Well, maybe I won't. What's the weather supposed to be this weekend? Anybody know?
Rain.
Well, screw it. Okay. Well, it's George. How are you? How are you?
They have not had a break. Can I let them take a quick break?
Yeah, just trying to decide